Good morning, boys and girls, and again we are coming back to the topic of penicillin after its introduction in the previous class. And in that class, we have discussed vividly about mechanism of action of penicillin. And in this class, we are starting with the recapitulation of our old memory. So let us start with the basic idea about mechanism of action of penicillin preparations. The action of penicillins requires the presence of a cell wall, and it's basically a cell wall synthesis inhibitors, and that contains usually peptidoglycans. So peptidoglycan is the major structural component of the bacterial cell wall that is cross-linked into a net-like structure what surrounds the bacterial cell. So in the next picture you will see how the peptidoglycan is linked into a net-like structure, it's cross-linked into a net-like structure, and it surrounds the bacterial cell. In case of gram-positive cell, it is in the right-hand side. Whereas in the left-hand side, in the gram-negative cell, you see an outer membrane which is lying at the top of the peptidoglycan, and hence it is difficult for penicillin-like drug to penetrate through gram-negative cell wall. This kind of structure made by peptidoglycan will provide strength and rigidity to it, and it protects the cell from osmotic rupture. So the end of a bacteria is usually happened by osmotic lysis or osmotic rupture. Transpeptidase involved in cross-linking and other enzymes located on the cell membrane are called penicillin binding proteins. These enzymes act as a binding site for beta-Lactams. So this is again, you can see the difference in the structure of two bacteria, gram-positive and gram-negative, and how the beta-lactamase enzymes are being placed. And then it's mentioned that peptidoglycan is a carbohydrate composed of alternating units of N-acetylmuraminic acid and N-acetylglucosamine. The N-acetylmuraminic acid units have a peptide side chain which can be cross-linked from the L-lysine residue to the terminal D-ALA link. ALA stands for alanine on a neighboring NAMA unit. This is done directly in gram-negative bacteria and via a pentaglycine bridge on the L-lysine residue in gram-positive bacteria, which again will be seen in the next picture. When there is weakening in the bacterial cell wall, it makes the organisms vulnerable to rupture by solutes in the surrounding medium. A cell wall synthesis occurs during the growth phase, and the antibiotic is most effective against actively multiplying organisms. So in this picture you will see the glycoprotein polymer, N-acetylmuraminic acid, and adding with another N-acetylmuraminic acid. Basically, in between the fourth and fifth is the reaction site, and penicillin is blocking the steps over here. The transpeptidation or transpeptidase reaction or penicillin binding protein will actually act here, so that these things, this cross chain is made from the lysine residue, and you see the kind of cross linking being made here. And here, in another way, you can see how the cross linking has been made and how the beta-lactams actually prevent the cross linking peptides from binding to the tetrapeptide side chains. So it's acting on the rapidly multiplying organism or actively multiplying organism, and it's preventing the cross linking of cell wall. These drugs are basically bactericidal in nature. So in conclusion, we can say that these drugs are cell wall active agents. That means it prevents the final step in the synthesis of the bacterial cell wall, and its range from narrow spectrum to very wide spectrum. It ranges from penicillin to piperacillin. How do they work? Precisely, the beta-Lactam binds to the penicillin binding protein. Transpeptidase is unable to cross-link peptidoglycan chains. The bacteria is unable to synthesize a stable cell wall, and the bacteria is ultimately lies due to osmotic pressure. Penicillins and cephalosporins kill bacteria only when they are actively growing and synthesizing cell wall. Otherwise, these drugs are going to be ineffective. Hence, if you combine penicillin with tetracycline, it's difficult to see any positive effect from the part of penicillin, because tetracycline will prevent the growth of microorganisms and penicillin will not get actively growing or rapidly multiplying organism for their action. So it's better to avoid a drug combination of penicillin with tetracycline. There are other penicillin binding proteins like S. staph aureus contains 4, E. coli contains 7. Different penicillin binding proteins have affinities for different penicillin binding proteins. High molecular weight penicillin binding proteins of E. coli are PBP1A and 1B, which include transpeptidase. The range of activity of beta-lactams is usually restricted to gram-positive bacteria, but once the spectrum is extended by giving some kind of adding some kind of side chains, and there's a little bit of more change in side chain, we'll see that outer cell membrane of gram-negative bacteria is penetrated, and initially it prevents diffusion of the drug, but beta-lactams after modification can make use of import porins in the cell membrane. Beta-lactams also have difficulty in penetrating human cell membranes, making them ineffective against atypical bacteria which inhibit human cells. So inhabited human cell, the bacteria which are inhabiting in human cell are becoming relatively resistant to beta-lactams. Any bacteria which lack peptidoglycan in their cell wall will not be affected by beta-lactams. Beta-lactams target penicillin binding proteins exclusively, and because cell membranes do not have this property of protein, beta-lactams are relatively non-toxic compared to other drugs which target common structure such as ribosomes. About 10% of the population unfortunately are allergic to some penicillin type beta-lactams. So the penicillin preparations, the natural penicillin is having bactericidal action. Its effect usually persists for 3 to 8 hours. After withdrawing penicillin G, which is basically a natural or biosynthetic penicillin. It is obtained from Penicillium notatum, and its commercial source is Penicillium chrysogenum. It is present in patient's plasma for a total period of 6 hours per day. So around 4 injections are required to cover almost the 24-hour period. The best effect is achieved by a concentration of 5 to 20 times greater than the MIC level, which inhibits growth. So in my introductory slide, I told you that mostly we are keeping the MIC level in vivo 4 to 8 times that of higher than the in vitro level, and this is the cidal preparation as well as this is the time dependent antibiotic. So the time for which it remains above the MIC level is going to play a crucial role in its cidal action. So penicillin G is available in 2 forms, the sodium, which is basically an injectable form, and the Benzyl penicillin is available in the form of its water-soluble sodium and potassium salts. Salts in a dry state are stable at room temperature for years. The aqueous solution, however, requires refrigeration. It deteriorates considerably within 72 hours. The Oxford International Unit for benzyl penicillin is equivalent to activity obtained in 0.6 microgram of sodium salt of benzyl penicillin. 1 milligram of sodium salt is thus equivalent to 1667 units of penicillin. A mega unit of penicillin is 1 million unit. The lower one is phenoxymethyl penicillin. It is the oral penicillin. Previously, it was very popular in the brand name of Pentid. And this is prepared to overcome the acid susceptibility of penicillin G, which is only prescribed via injectable route, whereas the phenoxymethyl penicillin can be given via oral route. So that is one advantage of phenoxymethyl penicillin potassium over penicillin G sodium. Its antibacterial activity is expected because it's effective mainly against gram-positive cocci and bacilli, and only some gram-negative cocci, and also against anaerobic organism called Clostridium tetani. Otherwise, it's basically a narrow-spectrum antibiotic. Among the spirochetes, it's Treponema pallidum. It's extremely sensitive to penicillin, and Leptospira infection responds moderately. Though it is effective against actinomycosis, it is not useful against other fungi. Here is a photo of Alexander Fleming, who discovered this penicillin, and the story was been told in the previous presentation, and he got a Nobel Prize with the other two scientists. So this is the site of action of the penicillin. This 6-aminopenicillinic acid is responsible for its cidal action. But if by some means penicilloic acid is obtained from this penicillin, it will definitely cause some kind of allergy. So penicillinic acid is for its effectiveness, whereas penicilloic acid is for its adverse drug reactions. This benzyl penicillin is given orally. It's not given orally. It is given via injectable route. If it is given orally, it is inactivated by the gastric acid. The drug is usually absorbed from the duodenum if given via oral route. So, aqueous solution is rapidly absorbed, and subcutaneous or intramuscular administration is preferred. Peak plasma level is reached around 15 to 30 minutes, and drug disappears from the plasma within 3 to 6 hours. Absorption of penicillin from mucous membrane is erratic, and it is also variable. Hence, a high risk of sensitization accompanies the use of penicillin in such forms as lozenges or troche, which are therefore not recommended. It is widely distributed in the body after absorption. Very high concentration detected in the kidney, but its concentration in ocular, pericardial, pleural and peritoneal fluids is low. However, in the presence of inflammation, its concentration in these fluids is higher. The drug does not readily cross blood-brain barrier, but therapeutically adequate CSF concentration is achieved in presence of meningeal inflammation. So these two are contradictory statements. The drug does not cross the blood-brain barrier, but therapeutically adequate CSF concentration is achieved in the presence of meningeal inflammation. What does it mean? It means in presence of inflammation, penicillin can cross blood-brain barrier. It crosses the placental barrier. Approximately 60% of plasma penicillin is bound to albumin, and the remainder is present in the free form. Nearly 30% single parenteral dose is metabolized. Small amounts appear in bile, milk and saliva. The major portion eliminated via kidney. It is important to note that doubling the dose does not double the duration of effect because it's a time-dependent antibiotic, and that for continuous effect. Large and frequent doses are necessary. So that is one limitation of giving penicillin because recurrent doses are required. Neonates and infants in whom renal function is not adequately developed, individuals with renal insufficiency may require a kind of dose modification. In anuria, plasma half-life of penicillin is increased in about 10 hours. So adult with anuria, an adequate dose of treatment of a highly sensitive infection would be only 2000 units per dose. Rapid urinary elimination of benzyl penicillin necessitates this parenteral administration at 4 to 6 hours interval. Repository preparations are also available in the market. Repository means longer acting penicillin. So the repository penicillins are basically the benzyl penicillin and procaine penicillin. This benzathine penicillin and procaine penicillin, they are called repository penicillin because their action passes for 24 hours or more than 24 hours. It is relatively insoluble and release benzyl penicillin slowly when injected, and they thus produce relatively low but prolonged plasma concentration. These agents, however, are not useful for treating severe infections such as immediate high plasma concentration of benzyl penicillin is desirable. Those are usually given for the treatment of secondary syphilis and rheumatic fever. So benzathine penicillin and procaine penicillins are mostly prescribed for those purposes. If you add probenecid with penicillin G, it will prevent secretion of penicillin, and hence the concentration of penicillin is increased in the plasma. So urinary secretion is going to be prevented while co-administration of probenecid with penicillin G, and it will increase its duration of action. And by doing so, it is going to be effective in treating different kinds of infection. A single IM injection of benzathine penicillin 1.2 million unit is given in beta-hemolytic streptococcal pharyngitis. 2.4 million unit of single dose is given basically in divided doses in 2 buttocks, and it's an extremely effective treatment in case of secondary syphilis. So but before giving this kind of preparations, you always have to undergo proper skin test, which I have described while presenting adverse effect of penicillin. So skin test is mandatory before giving any kind of penicillin-like preparation to avoid anaphylactic shock. Anaphylactic shock is the most dangerous adverse drug reactions which we may encounter with penicillin. Otherwise, it's relatively a safe drug. Procaine penicillin powder is to be suspended in distilled water prior to injection, and dose is usually 6 lakh to 1.2 million units intramuscular per day. After a single dose, the peak plasma level of 0.3 units per ml is reached within 1 to 3 hours. The drug, however, remains in blood for 8 to 12 hours and in some patients for 24 hours. Aqueous solutions are stable for many months at temperature below 25 degrees Celsius. The powder is basically have a longer shelf life, but the preparation should be kept in the refrigerator, otherwise its efficacy will be lost. Fortified benzyl penicillin means is a mixture of 3 lakh unit of penicillin with 1 lakh unit of benzyl penicillin per milliliter. Such a preparation achieves a quick and high serum penicillin concentration on IM injection, and effective concentration persists for 12 to 24 hours. So basically we are achieving both the results. As I mentioned before, for all these penicillin preparations, you can add probenecid, and probenecid is basically a uricosuric agent. It competes with penicillin for tubular transport, delays its excretion. Basically, the secretion, tubular secretion is prevented, and hence it is administered orally in the dose of 2 gram per day. And it's a divided dose, and it is given along with penicillin. It raises the plasma level almost 2-fold to 4-fold, which is maintained for approximately twice as long as is maintained for twice as long as without probenecid. Therefore, it is sometimes used for this purpose. But this kind of formulation, probenecid, is not recommended in children below 2 years. Phenoxymethyl penicillin, or penicillin V, basically is a oral form of penicillin. Mostly 400 milligram preparations are prescribed. It is indicated only in minor infections like tonsillitis, relatively of its relative poor bioavailability. Nowadays, the better preparations are available like amoxicillin, ampicillin. Those are better formulations working in a case of upper respiratory infection, and those oral formulations are having extended spectrum. So, phenoxymethyl penicillin is basically losing its importance in clinical practice. In this slide, you will see the use of penicillin G is being indicated, and also some use of benzathine penicillin. The prophylactic use has been mentioned in this slide. Now I am coming to the next one, which is very important for you to understand the matter, and you have to select penicillin preparations on the basis of that. And those group of preparations are called penicillinase resistant penicillins. So penicillinase is basically a short-acting beta-lactamase enzyme, which is synthesized by those dangerous bacteria like Staph aureus or E. coli, or those being mentioned before. So the problem is those enzymes will destroy the structure of penicillin by inactivating the beta-lactam ring, and hence the penicillin is not going to be useful. Whether it's penicillin G or it's benzathine penicillin, or even the extended spectrum penicillins like amoxicillin, ampicillin, or even piperacillin, none of them are actually resistant to these kind of enzymes. So those penicillinase resistant penicillins are having different groups. The first group is isoxazoline penicillin, and it contains cloxacillin, dicloxacillin, flucloxacillin, and oxacillin. Whereas the others are methicillin and nafcillin. Methicillin is the first one, which was invented as a first drug from this group. As several strains of Staphylococci have developed resistance to methicillin, it is now rarely used except for laboratory testing for MRSA. The term methicillin resistant Staphylococcus aureus is used to refer to beta-lactam antibiotic resistant Staphylococci. Most of the methicillin resistant Staph aureus strains are resistant to cloxacillin, flucloxacillin, and all beta-lactam antibiotics. It includes imipenem, cephalosporins, and penicillins. So that is the biggest limitation of using methicillin. Again, the mechanism of actions are similar to that of the other things. Whereas you see the structure of oxacillin, it has no chlorine atoms, whereas cloxacillin, it has one chlorine in structure. Dicloxacillin, two chlorines in structure. Flucloxacillin is basically one chlorine and one fluorine in structure. So basically the structural changes making it resistant to that virulent enzyme, beta-Lactamase. So these resistant penicillins have the characteristic resistant to staphylococcal penicillinase mediated hydrolysis. It is restricted only to a few group of agents where probably the other penicillins are not effective, much less active compared to penicillin G. If penicillin G is getting susceptible enzymes, susceptible organisms, then it's going to be very effective, and these agents are of choice in all case of staphylococcal diseases, but MRSA is probably one of the most important matter, or the matter for which we are really concerned about. MRSA is resistant to all cephalosporins, all PRPs, hospital-acquired infections, resistant to aminoglycoside, clindamycin, erythromycin, tetracycline, but is susceptible to vancomycin, is susceptible to some other drugs, so even to meropenem. So it's not that methicillin resistant Staph aureus is cannot be cured by giving any preparations from outside. So solution is vancomycin, as I mentioned right now. Penicillinase resistant penicillins, MRSA, contain an additional high molecular weight penicillin binding protein with low affinity for beta-Lactams. And for life-threatening infections and those involving foreign bodies, with that, you have to use vancomycin with rifampicin. And cloxacillin, dicloxacillin like drug, that means the isoxazoline penicillin 250 to 500 mg orally 4 to 6 hours is suitable for the treatment of mild to moderate localized staphylococcal infections. Not a substitute to penicillin G anywhere, but all are relatively acid stable, but food interferes with their absorption, so it should be given before food. It's not like amoxicillin where food is relatively causing food has no involvement in the absorptions of those extended spectrum drug. Variability in intestinal absorptions means seen, and the route best preferred for severe staph infection is usually parenteral. So whenever you feel that it is going beyond your hand, you just change the route of drug administration and will change from oral to injectable. Thank you so much for your kind hearing, and in my next presentation I will be talking on the aminopenicillins and other extended spectrum penicillin preparations. Thank you.